Yes, now recording. Perfect. So everybody, thank you so much for joining us this evening. Welcome. As I was saying before, I am Gila and I work for Genetics. My role there specifically focuses on me being the education, research, and outreach manager. And I'm so grateful for all of you that have joined us here tonight. This is our third event in the series called Diving into Our Genetic Pool. And this is a series that is very special to us because at Genetics, we really believe in the power of knowledge and really ensuring that everybody has this information accessible to them. This series came about because we wanted to share information on genetic testing, assisted reproductive technologies, their regulations, the ethical, moral, and different dilemmas that can encompass some of these technologies. And we wanted this information to be available to everybody. So we're very excited because this evening is our third evening session. After two very successful events, we are now very proud to put together this one, which is entitled the Science and Ethics of Genetic Testing. So everybody, please welcome, and I hope you enjoy this evening. So just before we get started, I want to introduce our speakers. And unfortunately, we were supposed to be joined by Rabbi Weizmann from the Puah Institute, but he had a little emergency and he was no longer able to join us. However, we do have a very special guest with us, also from the Puah Institute, and that is Rabbi Ellen Segelman, that you can see here on the screen. He is the rabbinic director of Puah in America, and he has a wonderful bio. So after studying in Israel for 2 years at the Yeshiva Kerem, Rabbi Segelman attained a BA in psychology from Touro College, Lander College for Men, as well as an MA from the same graduate college in Jewish studies. Shortly after he completed his semicha, he was appointed as a Shoel Mashiv and Rebbe in the Lander College for Judaic program. In 2016, Rabbi Segelman became the rabbinic educator at the New York Medical School and Touro College of Dental Medicine in Vail, New York. Rabbi Segelman currently resides in Los Angeles, California. So for him, it's midday and probably much nicer weather than for us. And he serves as the rabbi of the Young Israel in Hancock Park. So this is one of our first guests. Our second guest is Cheryl Berlin, and she is the lead consultant genetic counselor at the Northwest Thames Regional Genetics Service here in London, and she's been appointed in this position since 2018. She graduated with a Master of Science in Genetic Counseling from a university in South Africa, and has worked as a genetic counselor and research assistant, a scientist focusing on fetal alcohol syndrome outside African Institute for Medical Research. Cheryl moved over here to the UK in 2001 and worked in research fetal medicine unit at the UCLH hospital for 2 years before she started her first role as a genetic counselor. She obtained her UK genetic counseling registration in 2004 and has since then worked in prenatal, neuro, general, and cancer genetics, but mostly she's been specializing in cancer genetics since then. She is also on the Cancer Genetics Group Council and has a key role in organizing 2 yearly conferences for genetic counselors, and has an active role in training and assessing trainees and those that go on to become genetic counselors into the profession. So this is our esteemed guests. Before I pass on to Rabbi Segelman, who will introduce us to the ethics and moral dilemmas of genetic testing, I just wanted to introduce our speakers and just give a brief talk on genes. So genes have a very specific function in our body, and they are very important for the way we develop and the way we are. So for instance, we know that we inherit 2 copies of every gene, one from our mother, one from our father. And this is very important. As I was saying, genes work very specifically. So if we can imagine our genetic code as a book telling a story about us, our genes tell a story about who we are and as well as how our body works. So for instance, from the most basic thing to the way our hair looks, the way our eyes, the color of our hair, the color of our eyes, the shape of our nose, the most basic things to the way our organ systems work. So everything is determined by our genes. If there is a change or there is a mutation in something in one of our genes, then this can lead to a genetic disorder. And unfortunately, this is quite common, especially in the Jewish population, where there are several genetic disorders that do appear more in our population than in the general. And this is one of the reasons why Janetics exists. So for some of you, Janetics is a charity that you've heard about before. For others, maybe it's not. But Janetics is just a charity that came about in 2010 and initially started off as a charity that just wanted to focus on raising awareness, educating and talking to people about the different Jewish genetic disorders. In 2014, screening started. And since then, Janetics has now screened over 5,000 people. We have found over 7 carrier couples, and testing has very much become part of our day-to-day life at Janetics. So we screen for various reasons, primarily because we want to give people the power of knowledge so they can make informed decisions about how they want to go about having families, and as well as so they can know more about themselves. And we do this in 3 main ways. We test in high schools, so sixth form students above the age of 16 can be tested. We test in the universities, and also we test in a clinic where anyone that is in a relationship or in a couple, married, or older individuals that didn't have the opportunity when they were in school or university to be tested. So this is a form of genetic testing. I'd like to also introduce this evening perhaps an also known form of genetic testing, which is consumer-based genetic testing. Some of you might have heard of 23andMe and different forms of testings. So this is slightly different than what Janetics offers. We offer a very responsible screening service where individuals have to meet with a genetic counselor and where everything is explained to them and they have information. Other consumer-based testings offer different service where all individuals need to do is do a test, find out which conditions they're carrying or not, and then this way find out. It's less responsible in a way where they pay for a simple fee just for testing, and then they have to go on to pay again or ask for a different service to have genetic counseling. So just to give a little introduction to the different types of testing. And now, without further ado, I'll pass over to Rabbi Segelman, who will tell us a little bit about the ethics, moral, as well as Jewish perspectives to genetic testing and all the different implications.
Thank you very much. It is a pleasure and an honor to be here. Excuse my American accent if you don't understand me. I'll try to speak clearly. But it really is an amazing honor to speak with you this evening, afternoon for me here in LA. But I think that the fact that we're coming together and discussing genetics and genetic screening within the context of religion, Judaism, the morals and ethics behind such an important endeavor is really crucial, because it speaks to the very core of what Judaism is all about. It's about life. There are so many commandments in the Torah that tell us to live, and we have to choose life, and we have to live healthy lives. And all of that, it encompasses so much of what we do. And one of the areas that it encompasses and that it speaks to is this area of genetics. And it's also a type of part of life where many people kind of shy away from it. They hear genetics, they kind of get closed. They think it's something scary. It's something that reminds them of school. But it really is very relevant to each and every one of us. And I really appreciate this opportunity to share with you some insights from the Jewish religion, from the Jewish perspective on genetics in general, genetic screening, and more specifically. The rabbis of the Talmud were very aware of genetics. The Talmud records many different cases where genetics plays a critical role. I'll give you an example. The Talmud speaks of a family, a couple that has a child, a baby boy, and everyone knows on the 8th day of that baby boy's life, we have a brit milah. The baby has a bris. In a normal circumstance, the baby has his circumcision, has his bris, and the bleeding is not an issue. The baby's health is not compromised. But let's say, unfortunately, chas v'shalom, no one should ever experience such a thing. The baby perishes, the baby dies. The Gemara then says this couple has another baby, and the baby boy, yet again, has a bris. But to their dismay and to their horrific eyes, they see that the baby dies. And it happens a third time. And here the rabbi's question, should we really be going ahead scheduling a bris for this new baby? Because we know that there is an issue over here that these children don't survive the bris. And the Gemara tells us, Chazal tell us, the rabbis of the Talmud tell us, at a certain point, there's a debate, because we wouldn't be Jewish if there was no debate. There's a debate after 3 babies, after 4 babies. At what point do we draw the line and say, no more bris? Why? Because they have recognized that there is a genetic issue here that is causing this baby to, unfortunately, not survive the bris. And then the Gemara goes even further. The Gemara says there was a case of a woman who had a baby, and her baby died after the bris. Her sister had a baby, and that baby died after the bris. Her sister, so we have 3 sisters over here. Each one had baby boys, and after each of their respective bris, son's bris, the baby dies. The Gemara says not only will we tell that family that had son after son after son, but even in a case where the sisters in different families, in different locations, one could be in England, in Israel, in New Jersey, in Los Angeles, but there was all these different sisters had their sons, and the sons did not survive the bris. The Gemara says, don't do any more brisin for any of the other sisters, because it must be that these sisters carry within their family, in their gene pool, some type of issue, which we know to be hemophilia, some type of issue that blood clotting that the blood doesn't clot properly, that the babies don't survive the bris, and therefore it must be something that's in their gene pool, and will tell another sister when she has a baby boy, listen, I know this is your first child, you've never had a bris before, you've never made a bris before, but your sisters have all experienced tragic outcomes from their bris. You, with your first baby boy, do not go ahead and circumcise that child. Why? Because we project and we expect, based on the history, something will happen to your baby perhaps, and we don't want to risk such a horrible situation. The Gemara tells us, Chazal tell us, the rabbis tell us that certain people shouldn't marry. If you have someone very, very tall, you shouldn't marry someone very, very tall, because your children may be super tall. And also, if you have 2 people that are very short, abnormally short, they shouldn't marry because maybe their children will be abnormally short. The Gemara says if someone's skin is too white or too dark, they shouldn't marry someone with the same features, because that may manifest and express itself in the children, putting the children at a disadvantage. Yet another insight where we see that the rabbis of the Talmud were aware that 2 people with their own genetic background coming together could cause an issue with the children. Finally, the rabbis tell us that you have to watch out for certain people not to marry into certain families that say that the Gemara says mishpachat nichfin, which we'll define here as epilepsy. People who are epileptic, families that contain epilepsy within the family, be very careful before marrying into that family. Why? Because the Gemara, Chazal, the rabbis knew that that is not a isolated issue, but that issue is going to now be part of your gene pool, is going to affect your children and grandchildren, and you will be perpetuating the epilepsy to your future generations. And that statement of the Gemara was actually the springboard for much debate, for a very serious argument in the Jewish community. What am I referring to? I'm referring to the discovery of Rabbi Eckstein in Brooklyn a number of years ago, or maybe 45, 50, 60 years ago, whenever Dor Yesharim began the initial homework. What happened was Rabbi Eckstein was an individual who had children who unfortunately passed away from Tay-Sachs, and he was thinking to himself, I am a normal person, I'm a healthy person, I'm just a carrier of Tay-Sachs. My wife is a normal person, she's a healthy person, but she is also a carrier of Tay-Sachs. Together, our autosomal recessive gene that we're both carrying together will create a 25% chance of each pregnancy being a pregnancy with a Tay-Sachs baby. I don't want to get into the mathematics but let's just take that for when we as a given, when we talk about recessive genes. So individually, the both parties are totally healthy. When they come together, it causes there's a 25% risk of each pregnancy, not a 25% risk of all the children. Each pregnancy has a 25% risk of that pregnancy being with a genetically abnormal child. So Rabbi Eckstein began to discover ways that we could identify Tay-Sachs carriers and see to it that they won't necessarily marry. At that time, there was no technology to intervene, that they wouldn't marry to prevent the spread of Tay-Sachs. What was one of the major oppositions? It sounds like a fantastic idea. No, I mean, it sounds like the best thing since sliced bread. The issue was, the rabbis had told us, be careful, don't marry into a family with abnormal genes. Don't marry into a family that has some type of genetic abnormality, a genetic disadvantage, because it will affect your children and your grandchildren and future generations. So the question was, if we have an organization that's purpose is to discover genes, abnormal genes, so we are creating all these tainted families in the Jewish community, and no one is going to want to marry anyone. And that was a horrific thought to fathom. And it was for that reason why, at first, the rabbis of the community did not accept Rabbi Eckstein's proposition to open an organization such as Dor Yesharim, because we didn't want to uncover and reveal the various abnormalities that people have. Fast forward a number of years, fast forward a tremendous amount of education from the rabbinic side, as well as the general public. We understand that just because I have Tay-Sachs, just because I'm a carrier of cystic fibrosis, just because I'm a carrier of familial dysautonomia, you name your autosomal recessive gene, whatever it may be, that will have no impact on my children as long as my wife doesn't share that same genetic abnormality. And as always, new ideas, new concepts take time to digest them. But thank God, Baruch Hashem, we're able to sit here many years later and speak openly about genetics, speak openly about the various organizations such as Genetics that we have here, to help the community screen and see to it that children can be born, healthy children can be born, even though we have the Jewish population doesn't necessarily, we're pretty high on when it comes to genetic disorders. Ashkenazi Jews we're usually at the top. We usually have the greatest proclivity to all these issues, but yet we can still marry and we can still have children thanks to these organizations. What ended up happening, the more education became available, what ended up happening was the great poskim, the great halachic decisors of Jewish law, such as Rav Moshe Feinstein. Rav Moshe Feinstein authored a letter in which he was convinced that, given the circumstances, that at the time, Rabbi Eckstein had promised him that all of the results would remain private, and no one would find out who's the carrier of what. That's really how Dor Yesharim began, and I think even today is how they practice with a closed panel. Rav Moshe agreed to give his blessing to such an organization, and not only that, and this is really what's important for us today, he wrote that if a person doesn't screen for his genetic panel and doesn't see what he's a carrier for and what she's a carrier for, to see to it that the couple is compatible, it's like walking into the street without looking both ways. You could say, oh, how could I go ahead and test myself to see what I have and what my wife has, what my husband has, this and that? Isn't that going against Hashem? Didn't Hashem put me in this world and I'm supposed to be what the Torah says, tamim? I'm supposed to be pure. I'm supposed to not think too deeply into these hidden things. Says Rav Moshe, that's not hiding. That's not revealing something which is hidden. That's being, excuse my excuses, that's being stupid. To walk into the street where there's cars on both ends, on both sides of the street, double way traffic, you can't walk into the street like that. That's foolish. And Rav Moshe writes, and he concludes, that given the fact that we have the technology available, we have to take advantage of it, we have to test, and we have to see to it that we can give birth to healthy babies and continue the Jewish religion in the most healthy and responsible way. Many years later, where we became even more educated, so we realized that it's time for us to have an organization where we can have organizations that will even open the panel, where we could see what we have, empower us to know what are we carriers for. Knowledge is power. So thank God organizations like genetics and events like these perpetuate and help us educate ourselves. And that awareness is so important for our continuing development and continuing advancement in the world of genetics, to really, really be able to utilize technology and everything it has to offer and have healthy families. One of those, and I'll end with this, one of those technological blessings that we have in recent years is something that's called pre-implantation genetic diagnosis, PGD. And PGD is a technology where, utilizing the reproductive technologies of IVF, of in vitro fertilization, couples who are actually carriers, let's use the example of Tay-Sachs because we spoke about it before, couples who are carriers of Tay-Sachs, a husband and a wife, which, according to statistics, should yield a 25% chance of every pregnancy being a Tay-Sachs pregnancy, we actually have technology today that those children, that couple can have children. They can have 10 children, 15 to 20 children, and none of those children will have Tay-Sachs. How so? It seems statistically impossible. Because if they do IVF, if they do in vitro fertilization, harvesting her egg and taking his sperm, fertilizing the egg in the lab, in the fertility center, and then before implanting it back into the uterus, but actually screening, biopsying that embryo and screening that to see which of the embryos are carriers of Tay-Sachs, we can identify which embryos have Tay-Sachs and which embryos do not. The embryos that have Tay-Sachs we can discard, and the embryos that do not have Tay-Sachs can then be implanted into the woman, ensuring a healthy pregnancy without any issue of Tay-Sachs. That is a technology that was not around 10, 15 years ago. That was the only option if we're dealing with a couple that has a genetic abnormality and they share the same recessive gene. Either they take the risk, or they terminate the pregnancy, or they don't have children at all. But now there's a fourth option, which is an amazing, amazing option where couples can have IVF with PGD and have pregnancies with healthy children, not having to worry about the genetic abnormality. So I think, just to conclude, and I'm happy to address any questions later in this evening's event, but to conclude, I would like to present the Jewish perspective, the Orthodox Jewish perspective towards genetic screening, and that is to remind you of the words of Rav Moshe Feinstein, not to screen, not to put yourself in the most prudent an appropriate and responsible position is simply like walking into a street with cars going both ways and blindfolding yourself before doing that. I have spoken to many rabbis who have disagreed with this, but I believe this is a mainstream approach, and it is certainly the approach of the Pua Institute, recommending and encouraging couples, singles, before marriage, after marriage, to be aware and to be receptive to the various programs that are available to the public, to see to it that we can continue to have children, Jewish children, healthy Jewish children, and be able to populate this world with those beautiful smiles, with the beautiful Jewish souls that Hashem is so proud of. Thank you.
Thank you so much, Rabbi. I'm sure definitely a lot of food for thought there. So now I'm going to quickly pass on to Cheryl, who will tell us a little bit more about people's experiences and their real life dilemmas and questions when undergoing some of the technologies that the rabbi has mentioned and when facing the decision on whether to yes or not test.
Thank you, Gila. It's always hard to follow a rabbi because they always speak so eloquently and so passionately. So thank you for that, Rabbi Siegelman. And really, thank you.
You have the accent, so whatever you say, you're much better than me. You got it.
Oh,
You're
well,
good.
mine's South African, so, you know. So, well, thank you to the Janetics team for inviting me, and thank you to all of you in advance for listening to me drone on. When Gila first asked me if I'd happy to be on a panel to discuss the ethics of genetic testing and the impact on our patients, I felt rather overwhelmed at the enormity of the subject. Genetic testing refers to so many situations and affects people at so many different life stages. I naturally asked her to break this down for me, give me a focus, give me some guidance. And it dawned on me that is exactly how our patients feel. Overwhelmed by the enormity of some of the decisions they must make, impacting not only on themselves, but on those around them and impacting on future generations. Such responsibility. We went on to discuss that Janetics' main role, as you've already heard, is to offer preconception testing for recessively inherited genetic conditions. And this refers to conditions where a child inherits two non-functioning or faulty copies of a gene and is affected, and each parent has one non-functioning and one functioning copy of the gene and is expected to be unaffected. And this is done to assist in family planning. So I will try focus on this. But first, what do we mean by ethics? Talk of ethics and ethical practice occurs within a wide range of different contexts. For instance, we might be asked to act or choose ethically. This often involves being encouraged to consider the interests of others as well as our own, people, animals, ecosystems. We might be asked to adhere to a particular moral code, religious, cultural, institutional. We might be talking about an academic discipline that someone might study, like applied ethics. Or we might be talking about professional policies or procedures, so codes of conduct, clinical guidelines. And there are four main clinical or ethical principles or guidelines that underpin many medical practices. And these are autonomy, which are based on the respect of others, and the idea that people make their own independent decisions. And of key importance is that they are provided with all the relevant information, allowing them to make informed decisions free from coercion. Then we have beneficence, looking for the patient's best interests. Then the third one is non-maleficence. Yes, they are difficult to pronounce. And this is where care should not result in harm to patients. So I'm sure most of you have heard of the phrase, above all, do no harm. And lastly, justice, a mix of ethical and legal principles defined as a form of fairness. Now, I'm not an ethicist, and my remit was really to give some context and real life examples. And to do that, please allow me to take you on my journey of prenatal testing and my experience. When I began my career, we could offer preconception testing to a very limited number of people, and it was usually based on personal family history or them having had an affected child. We could also offer limited carrier testing to some population groups, for example, the Ashkenazi Jewish population, where we could offer Tay-Sachs screening. The purpose was that so that these couples could make informed decisions around family planning. They could opt not to have a baby, to adopt, to use sperm donation or egg donation, or to have testing in a pregnancy through invasive genetic testing, which carries a miscarriage risk, and the purpose being to end an affected pregnancy. So couples would come along to us for carrier testing and often for testing in a pregnancy. Things that mostly affected decisions around these testing in pregnancy would include their past experience of particular conditions in themselves and family members, their religion, their family, their community attitudes, and timing of testing. And one of the first couples I saw in the UK was a lovely couple whose baby was shown to have concerning features on an ultrasound scan at 20 weeks. Now, those of you who have gone through a pregnancy will know it is common practice to do screening using ultrasound in pregnancy. An invasive prenatal test was done, and this showed that the baby had 3 copies of chromosome 18. This is known as Edwards syndrome. The lady was now 22 weeks along. Most babies with Edwards syndrome don't survive to birth, and if they do, most of them will sadly die within the first year of life. The couple were naturally devastated. It was their first pregnancy, and it was a much-wanted baby. They were faced with extremely difficult choice of whether to continue the pregnancy or have a termination. And questions the couple asked, as many do, included, what will my family think of my choice? What will my community think? Many people are pro-life, and many others feel that it's wrong to bring a baby into the world who may suffer and may ultimately not survive. How would I cope with a baby who's very sick? Who will support me, whatever my decision is? And do I deserve that support? And that leads us to consider what is in the best interest of our patient. And who actually is our patient? Is it the parents? Is it the unborn child? And what about do no harm? Would continuing the pregnancy or having a termination be more beneficial or harmful to the couple? Something just really food for thought for everybody. How would you feel about ending a pregnancy in this situation? Does it feel that something that is acceptable to you? And if we think about another couple who had testing in a pregnancy and the test confirmed the baby had Down syndrome, does that change people's feelings about whether termination of pregnancy feels acceptable? And I do use the word feel very carefully there. Babies with Down syndrome are more likely to survive, and people with Down syndrome can have a good quality of life. But who judges quality of life? What about the quality of life of the parents, of the other siblings? Who will care for the child when the parents are deceased? Does how far along in the pregnancy influence people's decisions? What about severity of the condition? Who determines what is severe? What about the mental health of the parents? The financial burden on a family? And these are all questions that all of our couples face. In around 2006, technology allowed us to sex a pregnancy on a blood test done at the mother at around 9 to 10 weeks gestation. Now, this was not used in the UK for sex selection based purely on whether someone wants a boy or a girl, I hasten to add. It was aimed at pregnancies at risk for conditions that affect boys and where girls tend to be less severely affected, if at all. If a woman opted for this, then the idea is that if the baby is shown to be female, then no invasive testing is done, therefore not putting the pregnancy at risk. But if the baby is shown to be male, then there would be a 1 in 2 chance that the pregnancy would be affected, and we could offer them invasive prenatal testing. I had a lady who presented at 8 weeks gestation. She was no longer with her partner, and she told me she had a brother with a condition called Duchenne muscular dystrophy, who had sadly died. This is a muscle wasting condition affecting mainly boys, who sadly often become wheelchair bound and often die in their late teens or early adulthood. She was asking to have fetal sexing, but not for the reasons we expected. She felt quite able to raise a boy with Duchenne's, and in her words, do a better job of it than her mother. She wanted fetal sexing and wanted to have invasive testing only if the baby was female, as she did not want to have a carrier daughter who would have to get on with things on her own and have to consider testing in a pregnancy. Although this was a rather unusual request, and clearly there were some psychosocial issues at play here, It was a stark reminder that people are different and have different value systems. And if we focus on the ethics for a minute here, we have to remember it's not just the patient and their families and community, but also the genetic counseling staff, the laboratory staff, doctors, midwives, who are all impacted and all have their own personal feelings, professional guidelines, morals, and ethics to adhere to. Laboratory staff, in this case, were not comfortable offering a testing with view of ending a pregnancy of a potentially healthier carrier females. And how would doctors feel about terminating a possibly healthy female because she was a carrier? And consideration of prenatal diagnosis gets even more murky for conditions where not everyone with the genetic change will develop the condition, as it is variable in how it presents. So some family members may be unaffected or have a mild form of the condition, while others a much more severe presentation, all of whom carry the same genetic change. Now, we cannot predict based on the genetic test and the genetic change how the condition will present, or even if it will. This is particularly difficult for families to make decisions, especially now that we can offer something called non-invasive prenatal diagnosis for a limited number of conditions in some families. This is known as NIPD, so I will just use that to shorten things. So the great advantages of NIPD is there's no miscarriage risk. How fantastic, what an advance in technology. However, it comes with its own set of ethical dilemmas and problems. I recall a case where carriers of a variant in a CRIT1 gene are at serious risk for a condition that results in cerebral cavernous malformations, and they may experience serious symptoms such as headaches, seizures, paralysis, hearing or vision deficiency, and bleeding in the brain. It is very variable in how it presents even within a family, and around 40% of people with the condition have no health issues at all. The father had a CRIT1 variant and was affected and had multiple seizures and several surgeries as a child. They initially opted for NIPD and told the consultant it was an unplanned pregnancy and that they would end the pregnancy if the baby had the same genetic variant as dad. The testing showed the baby had indeed inherited the CRIT1 variant. The couple have opted to continue the pregnancy. So what changed their minds? Had they been truthful to themselves and to us about what they had planned? Had they actually really thought things through before requesting testing, despite numerous conversations with the genetics team? Is testing now too easy without consequence of miscarriage to give pause? Or were they coerced or supported by family and friends? And it raises the question of testing for information only. Is this ethical? Is it a good use of NHS resources? Some may argue that by knowing the status of a child, even in pregnancy, they can be offered appropriate management. Parents can feel they've done everything they can to ensure the best care for their child. However, literature has shown it can have negative impact on family dynamics, and we should rather only test a child should they become symptomatic. Whose right is it to decide what is best for the child? The parents, the healthcare professionals? And then we think about prenatal testing for adult onset conditions. We had a couple where dad carries a BRCA1 variant. So this is a variant that predisposes to an increased risk of mainly breast and ovarian cancer, but may have a small increased risk of male breast cancer and possibly prostate cancer. They requested fetal sexing with the plan not to undergo prenatal testing if the baby was male. The baby was shown to be female and sadly shown to be affected, and the couple opted to end the pregnancy. So how do we feel about prenatal testing for adult onset conditions? There are management options, there are screening options. Treatment is better than it was, and in 30 years is likely to improve. Does that change how we feel about genetic testing in these circumstances? What about testing for adult onset conditions that are life-limiting, that have no cure or treatment, like adult onset neurodegenerative conditions? So, for example, early onset Alzheimer's. If couples are wanting testing, in prenatal testing and the baby is shown to have inherited the genetic change, meaning they will at some point develop the condition, and the couple opt not to end the pregnancy, we have effectively tested a child who may, if they were given the choice, opt not to have testing, as many people do for these conditions. And sadly, this does happen. We generally have very strict guidance about genetic testing in children for adult onset conditions. Essentially, we don't. There is also, as Rabbi Siegelman mentioned, the consideration of pre-implantation genetic diagnosis. Again, another marvel in technology where we can test embryos and then only implant those that do not have the genetic condition we're testing for. Now, in the UK, it's only licensed for conditions that are considered to be serious. Who decides what is serious? What I feel is serious may not be serious to somebody else. What my experience of a condition may be different experience to somebody else. I've recently been told that one of the services in London have changed their policy, and if you are doing genetic pre-implantation for BRCA carriers, as we talked about, they will implant males who are BRCA carriers. Again, that raises another issue. Is the aim not to have eliminated risk rather than perpetuate it? And again, with PGD, there's a lot of resource issues. So while you mentioned you can have 20 pregnancies, unfortunately on the NHS, the funding doesn't quite stretch that way. And people are only funded for a first child. There are so many very many different issues in ethical issues that are faced by the families we see. And the dilemmas only increase as the technology improves. There are issues around testing in pregnancy, childhood testing, sharing information with the family versus confidentiality. Whose information is it? Is it an individual's information? Is it a family's information? And unfortunately, there have been many a case where family members do not wish to share, and children can be born with genetic conditions because the information hasn't been shared. People have the right not to know. We also need to ensure informed consent and capacity to make decisions. And with even greater technology, where we're able to do whole genome sequencing, meaning we're able to look at the whole genome, there's the concern of incidental findings. When we're testing for childhood learning disabilities, they may pick up a risk of cancer. All these dilemmas result in conflicts within a person, between couples, and families, and between the patient and the healthcare professionals. And this is just the tip of the iceberg, but I hope I've given you a little flavor of some of the dilemmas that our patients face. Thank you.
Thank you so much, Cheryl. Definitely a lot of flavor you've given us. And thank you for each case and explaining everything so well. I'd like to now open the floor to questions. So if anybody has any comments, thoughts, questions, please do reach out. We're here to answer them and to continue the discussion. Let's see. I think Stuart has a question.
More observations. My name is Stuart Manning. I'm a retired GP. I do a lot of work with cancer. One of the things I'd like to ask the rabbi is, what is the ethics of destroying the embryos that we don't implant? How does the religion feel about that? Another question, another point would be, people, when they have IVF, don't always produce many embryos that are suitable. So what happens if a couple keep producing embryos that are carrying a gene? That makes the decision more, I mean, and the other thing is that it's something that is not really understood. It's very difficult because we're dealing in areas that we don't understand. And once you start radically trying to eradicate certain conditions, you can leave yourself open. The classic example of this is, sickle cell disease only basically survived from 1 million years ago, because sickle cell disease, even though it's a serious condition, the people with sickle cell disease were resistant to malaria, so they survived. So there are observations, and it's just I mean, it's something that is difficult. And I think always, and the final thing is, when you're Jewish, you look at Jewish history, it's quite difficult, isn't it, to get involved with things like, perhaps destroying embryos that are abnormal when you look at what happened. And I'm not analogous to that, but it's only one step down the road. And the thing is, I'm always concerned about the regulations of these things. So it comes to things like, like assisted dying. They're all ethical decisions, but the implications of them are very serious. Those are my thoughts.
Thank you very much. There's a lot there, a lot to unpack. But one thing, at least from the halachic perspective, when it comes to Jewish law, so, this is a fascinating discussion. We can have a webinar all about the definition of the beginning of life and how it differs between various religions. Because certainly Judaism and the church disagree on the beginning of life, and it has real life ramifications when it comes to different patients in the fertility lab. The major issue, one of the major issues, is that we'll begin with, I actually feel uncomfortable beginning with the church, we'll begin with Judaism, but Judaism understands and believes that life begins with implantation. Prior to implantation, the embryo is not considered life. And I'll give you a fascinating real life example. There was a Jewish, I think this happened in Israel. There was a center, fertility center, and the doctors received an alert on Shabbat morning, that the power had gone out. And all of these embryos that were being frozen by liquid nitrogen with an electronic backup lost its source of energy, and slowly but surely the temperature was rising, and all of these embryos were thawing or were destined to thaw. We know when it comes to the laws of Shabbat, so the laws of Shabbat can be pushed to the side to save a life. Is this a life? Are these embryos life? Am I able to get into the car right now and turn on the car and drive so I can restore the electricity and the energy in that lab to protect those embryos? If there was someone who had an injury and needed to get into my car, I don't think twice. I turn on my car and I drive them to the hospital. Because as we mentioned in the beginning of this evening's event, Judaism wants life. However, life might not be in the embryonic stage. When the embryo is implanted, at that point there's life. And that's when really the abortion question hits the scene. Is there any room between 0 days and 40 days, and from 40 days to 3 months? Or is there any halachic difference between those different terms? However, Judaism across the board does not view an embryo as a life. And therefore, you would not be able to break and desecrate the Sabbath, and you wouldn't have an issue of discarding that wouldn't be considered an early abortion and early termination. The church disagrees, and therefore even PGD, even pre-implantation genetic diagnosis, where you have to biopsy an embryo and might have to discard an embryo, is not allowed in certain circles of Catholicism and Christianity. They don't allow that. I don't think that they allow PGD because of the status of life, which is determined even upon fertilization prior to the Jewish concept of implantation. So to answer your question from the perspective of Jewish law, an embryo does not have the status of life. And therefore, in terms of discarding unwanted embryos that are aneuploidy, that are not healthy embryos, which many of the labs would never, even if you paid them $1 million, they would never implant because it's highly immoral. It is permissible to discard those embryos. In terms of your question of the slippery slope, I couldn't agree with you more, because I think everyone, not just from a Jewish perspective, even the non-Jewish world, the entire world, who knows what this testing, what this screening is going to yield. Many of the genetic counselors themselves are not familiar with the nuances and the complexities of the diseases that they're screening for. And as we know, and again, this is for not even another webinar, for another webinar series, how genetic sequence, genetic manipulation, CRISPR, Cas9, I mean, gene editing, how that is going to impact the human race is just, it blows the mind. It is beyond comprehension how far this could get out of hand and how specific our children may be when we choose when you check off the boxes. I want blonde, I want blue, I want the athletic, this, I want him to score this on the SATs, and I want her to do. I mean, it's very scary. And I think the answer to your question is yes, it is a slippery slope, and we have to do everything that we can do within, what we think are the morals and the values and the and the systems that are set in place by rabbis, doctors, etc. We have to do what's available and responsibly, because it definitely can get out of hand. There's no question about it.
Yeah, I think it's also important to say when people do put in requests for prenatal testing, that whenever there is any sort of kind of wavering about how serious this is, the cases are taken very seriously. It's generally not just one person who would make a decision. It would be taken to a multidisciplinary team meeting. It would be taken to an ethics committee. It would be taken to a genetics forum. But it is really difficult because, again, everybody's concept's different. And what do you do about these conditions where they are so variable? And there has been, with new technology, what we call neurosusceptibility loci. So what they do is they are these genetic changes may cause a problem, but not in, but they may not. And a lot of the time they won't test for them if the risk isn't above a certain threshold in terms of the likelihood to cause a problem. But yeah, it's really tricky.
Okay, thank you so much for that question. And now I'll pass on to Katrina, who has a question.
Hi, thanks very much. Fascinating talk by both the rabbi and Cheryl, opening up so many thoughts. This is a question particularly for Rabbi Seligman. I'm very familiar with the Dor Yeshurim system, and from my understanding, it's very much focused on the recessive conditions in terms of the testing that they do and the anonymity that they have. Could you share, I know that you're not a representative of Dor Yeshurim, but if you could give some insight into the halachic perspective, the Jewish perspective on testing for dominant conditions like BRCA and the implications of that information, that'd be very interesting.
Right. As you said very accurately, I am not a representative of Dor Yeshurim. So it's hard for me to speak about that organization specifically, but whenever we speak about Dor Yeshurim, we have to understand where they're coming from. First of all, they're coming from a very, very closed and opposed corner. Meaning they really were shunned, and they were not given the permission to open up. Slowly but surely, they were able to infiltrate in a positive way and to get their message across. But they tread very carefully, and I know for a fact they started with a very small panel, again, recessive, autosomal recessive genes, and then in order for them to add even one more or two more to their very, very limited panel, they have to jump through hoops, this approval, that rabbinic approval. I mean, it's really, really difficult. And what we have on, at least in America, and it seems like similar in the UK, is that the other organizations that have the open panel test for way more, hundreds more genetic disorders than Dor Yeshurim does. So it's a very, so in order to, if you would even suggest something like a dominant gene, I mean, forget about it. They're never going to incorporate that into the panel. But more than that, the idea, the concept behind Dor Yeshurim is that they want to check compatibility between two people. Once you introduce a dominant gene, the dominant disorder, compatibility is irrelevant because the dominant gene will exist regardless of who the partner is. So it also doesn't speak to their model of, the product that they offer. In general, it reminds me of the question, what do you do? And this has happened to me countless times, unfortunately, because it's uncomfortable. But I'll sit down with a young couple, and they're sometimes even madly in love, ready to get married. And they thought, hey, wouldn't it be a good idea for us to do genetic screening before we pull the trigger, huh? And sure enough, they get their results back that he and she are carriers of the same very serious genetic disorder. And now the question is, what do we do? Do we go ahead with it? Or do we take this as some type of sign that it wasn't meant to be? How are you supposed to deal with such a question? So the reason why your question reminded me of that is because when we're dealing with a dominant disorder, it's not that this couple could break apart. They could, say goodbye to each other and marry other people. And both of those parties will be fine. Both he and she will hopefully have children, assuming that their partners don't have the same gene. But with a dominant disorder, it's not the case. It's going to continue. It's going to be present in the future. And with the advice that we give those couples who are going to stick it out and they're going to stay together until the end, and nothing you say can break us apart. So the advice that we give them, similar to whether it's the IVF with PGD route, or it's the route of getting pregnant naturally and doing prenatal testing, whether it's the NIPT or a CVS or an amniocentesis, and finding out what the situation of the fetus is in the pregnancy, and then either coping with it and dealing with it and having that birth, or terminating, depending on what, the advice that they get. So that's how we deal with the dominant disorders as well. In terms of BRCA, there's another, and Cheryl mentioned this, there's another nuance, another complexity to the BRCA, because if you have BRCA, it doesn't mean that you have cancer. So, I always tell people, I don't know how we are going to, if anyone here knows, please tell me, but how we're going to treat cancer in 40 years from now. We have no idea. We hope and we pray that when the doctor says, it looks like you have cancer, they're going to send you to the pharmacy. You're going to get a little a pill. You'll swallow the pill, and then you'll be finished. Who knows? With the rate of the advances in technology, we hope and we pray that will be the remedy one day. If that's the case, so then maybe being a carrier of BRCA, the BRCA gene, is not such a big deal. But we won't know that. So how do we deal with those cases when there's just a proclivity to cancer, but it doesn't mean that you're going to be sick, and it doesn't mean it could be, and we're talking again about your children. What you have is what you have. There's nothing you can do about it unless you get into the Cas9, the CRISPR-Cas9, but get your own gene sequence edited. But when it comes to your children, we're talking about 20, 30 years from now, 40 years from now. So it's a very, very complicated issue.
I guess one of the questions around that is also about, you were talking about halakhically and about marriageability. And I guess that's don't marry into the family with epilepsy. I guess our concern is people test for BRCA, then that would become an issue.
Well, again, there's the different timelines. When are you testing for BRCA? Are you testing BRCA after you got married? If you're testing for BRCA after you got married and it turns out that you're positive, so now you're married, you know this information, you're able to be as responsible and aggressive as possible, have your children as quickly as possible, remove the ovaries, remove the breast, whatever it is, to prevent onset of the cancer. Cheryl here? Oh yeah, she just
yeah. He is that.
The cancer. However, but if you're dealing with a woman who is single, let's say,
yeah.
So now you have this really serious piece of information, and holding on to sensitive information without disclosing might also be immoral and unethical before going into marriage, knowing something that the other party would really want to know about. And here you are kind of keeping it a secret. So I think that even under those circumstances, maybe testing after marriage as opposed to before.
Sorry, just to clarify, I know there's never one Jewish view on anything, so I'm not looking for a single view, but in the same way as there is clear majority endorsement for recessive testing, is there a kind of majority view in terms of the halachic testing for BRCA, or is that's not been established at this point? It's
less so. As I just alluded to, there's way more backing post-marriage than pre-marriage.
Right. Thank you.
Thank you so much for that, Rabbi and Cheryl. And now for the last question, I'll pass on to Rose.
Thank you. So I'm what they call a BRCA previver. I've known about family history of ovarian cancer, and I was actually only tested for BRCA myself, positive result after I'd already done the prophylactic surgeries to try and preserve my life. I want to pick up on a couple of things that have come up from both of the panelists who've been incredibly informative. I don't know, maybe I'll start with you, Cheryl. I'm very distressed. I have to be honest, it's quite triggering, the thought that a male embryo that has been tested and has been identified as BRCA1 might still be implanted in a situation where the sort of background to this testing in the first place is to perhaps eliminate embryos as BRCA1. For everybody else, just to be sure, there are still doctors out there who tell women, Jewish women and other women, that the BRCA can't come through the male line. They're dead wrong. It absolutely can. It was my maternal grandfather and his brothers who had the BRCA, and it's affected women in our family. The other thing is that there's now quite clear new developments, Rabbi Seligman, when you talk about knowledge is power, and you also talk about who knows what they're going to do with cancer treatment, it's becoming clearer that even men who get cancers like prostate cancer might actually have a BRCA cancer. It's not just breast and ovarian, and that what are normally considered untreatable, sorry, did I say prostate? I mean pancreatic cancers, if they are treated with the same drugs that have become more and more successful in dealing with ovarian or breast cancer, they may beat that pancreatic cancer. So the knowledge of a male that he may be a BRCA carrier could literally be life-saving for that male. And if that information is not available in the family, as it wasn't in mine, because we were just pre that whole moment in time when we started to learn about BRCA, any daughters that man may have over time may land up being whacked with diagnoses of ovarian cancer that could have easily been avoided had that knowledge been in the family, and had those women had the opportunity to have the close screening, to have the prophylactic surgery. So, I mean, I hear you, Cheryl, about all the nuances and all the different rights, but I'm just trying to paint a picture that is my lived experience. I spent years and years and years and years begging my brother to get tested because he has 2 sons, and I begged him for ethical and moral reasons to test himself. If he tested positive, we could have a discussion and he could have a discussion with his sons, because maybe at some point he's going to have granddaughters who are going to die of ovarian cancer like his mother and my mother did. So it's, when you take a real life situation like ours, anyway, thank God he did agree to test. He is negative. We know his wife's family doesn't have it. So end of the story. I now have a daughter who is BRCA positive. And we are certainly hoping that when her time comes to have a family, she will be able to have some evaluation done of or any sort of pre-implantation type of testing done. Just had to share that and had to sort of, raise my real sort of triggered response to what you had said, Cheryl.
Thank you, Rose. I really do appreciate that. And I think we had a similar response when we heard about that as well, is that we had some concerns around that, and apologies that this was triggering. But I think you raised so many really vital points around the issue of, with particularly things like BRCA, it only comes from the mother's side, which is so very not true. And I think with the idea of male embryos being implanted it would be a couple's choice. It is their choice what to do. And again, it's around what I think, Stuart, I think you mentioned around the fact that sometimes couples can go through the IVF and maybe not have any embryos that don't have the genetic change. And given, unfortunately, limited resource, and actually it's not an easy process. We talk about it, it's very blasé, but it's actually an incredibly difficult process and very anxiety provoking, stressful, that people may make that choice. But I think it is really important that men are aware of their status as well. And you're right, there is very much a move towards what we call precision medicine or personalized medicine, where knowing your genetic status and knowing the status of the tumor in terms of their BRCA-ness, if you like, is very important. It's not just BRCA, there are other genetic changes as well, will influence the type of treatment. And there is lots of research about what we call PARP inhibitors, which are known to be quite successful in treating, or not successful, at least better in treating BRCA cancers. And there are lots of trials, not just on the breast and ovarian, but also with the pancreatic, which generally tends to be BRCA2. And we do seem to, there is a slight increased risk of pancreatic. But, I am glad to hear that your brother isn't a carrier. And I'm glad to hear that your daughters are fully aware. And obviously when the time comes, I hope she gets all the advice that she needs so that she can make decisions for her and her family.
Thank you. Well, the big difference for my daughter is I'm around to be able to help. My mum wasn't around when I was at that point in life. So,
and she has that advantage, and that's the wonderfulness of having had this test, because it's not a nice thing. There's nothing good about it, except for the fact that actually you are born with these genetic changes. They are with you your whole life. At least you now can use that information to guide decisions and management. And really, we do appreciate you bringing your real life story, as Katrina's put in the chat.
Thank you so much for everyone for listening. Thank you to our speakers, Rabbi Segelman and Cheryl. It's really been so interesting, so insightful, and we're so grateful for everybody that joined. Just to conclude, thanks again, and please look out for our next event, which will most likely be actually on CRISPR. So very excited, and thank you. Thank you very much.
That was excellent. Thank you.
Stuart, I didn't get back to you. I just wanted one point, Cheryl, you reminded me that Stuart hit a question that I did not respond to. And that is, what happens if you do IVF multiple times and you unfortunately yield the same embryos with the same aneuploidy, the same genetic disorders? So I think that speaks to another webinar series about third-party reproduction, donor material. At what point does a couple make that jump from using their own genetic material to incorporating a donor's material? At a certain point, whatever that threshold is, it's different for everyone. At a point where you realize that I can't have my children and with my own genetic makeup, perhaps we have to introduce a donor, a third party.
So let me say one thing before I go. I helped the people in Leeds set up the BRCA journey. What is very obvious is that it does go through the male line, and you find the guilt of the people. It was actually a Jewish doctor in Leeds about pancreatic cancer, and his daughters both tested positive, and he spoke a lot about BRCA, but he was ridden with guilt because he'd passed it on to his family, and that's another whole thing. But it's been fantastic. I've really got a lot out of it. Thank you.
Thank you.
Thank you so much. Thank you again.
Bye.
Thank you, everyone. Have a good afternoon, Rabbi, to you.
Thank you. Bye now.
Bye.